like. Yeah. Okay, so I'm just introducing this topic of qualitative research as part of our ARC seminar series. And just to give you a bit of background about myself, I'm Neil Chadborn. I'm a researcher in public health. I've been working with or alongside the ARC for several years now. And I currently coordinate the East Midlands Research into Aging Network, which is linked to the ARC, and it's linked to the BICRE, if you know your ARC acronyms. If you don't, have a look at the ARC website and find out a bit more about it. The ARC is a great network of applied health research across the East Midlands, but it also links into similar centres across the country. So it's a great network to be part of for applied health research. My interests are around working with people with dementia, and also care homes and integrating care across general practice, community, etc., as well as more preventative topics of public health. So yeah, it's great to see you all today. And as I said, people are on different stages of their sort of research journey, as it were, or experience. Be great for some of you to make contact with each other and potentially develop a bit of a learning network through the ARC, through these short courses that are ongoing. I'm delivering another one on the 27th, so maybe I'll see some of you again then. And yeah, it'd be great to keep in contact with people and continue discussions, etc. So I'd be very pleased to help that happen. So anyway, on to qualitative research. What is it, and how can you get involved, or how can you understand more about it? As I said, it's a huge topic really, and I'll only be able to kind of scratch the surface or give you an introduction to qualitative research this afternoon. So what I plan to do, I'm just sharing my screen now. I don't know if it helps to put my face up beside the slide there like that. What I plan to do is basically check you in at the deep end and start by introducing a few research articles to show you the finished result of some qualitative research. And hopefully you've received an email with those PDF documents that you can have a look at as we talk this afternoon and after the session. Then from that sort of finished document, if you like, I'll try and work backwards to show how the authors, how the researchers got there. And in that way, try and explore how research projects are undertaken and how they're reported and shared, and what impact they can have. More of that later. So I'm going to start with just a brief introduction of why qualitative research. And in some ways, I think qualitative researchers, certainly in healthcare, social care, public health, are often kind of defending themselves or defending qualitative research against the broader topic, broader quantitative perspectives. So I think it's quite important for you to be able to argue the case, if you like, for why do you want to do qualitative research. And a couple of points that I'm bringing out here, numbers, etc., sometimes hit the target but miss the point. So what's the actual point of whatever the question that the quantitative project is trying to address? Also about values, value judgments are something that you can't put the number on. It's also about patient experience, and again, increasingly it's important to understand the experience of care, and that's increasingly recognized. And finally on this short list, who are missed by services. So patients are people who are receiving care, but who should be receiving care but for whatever reason aren't. And if we can't understand why those people are missing out, then we can't do more to reach them and hence address inequality and disparity. So those are just a couple of reasons to do qualitative. Just as a bit of background then to say a bit more about the difference, if you like, between quantitative and qualitative. As many of you will know, quantitative research is often about large sample sizes, questionnaires, measurements. It's about finding patterns with statistics. On the other hand, qualitative is about an in-depth exploration of a topic. Often interviews are involved. It might be exploring attitudes or values, as I said, things that you can't easily put numbers on. And what are they working towards, or what are they working with? Well, qualitative research applies social theory or tries to develop social theory. So, for example, an interpretivist theory. On the other hand, quantitative research uses a kind of science approach, which we call positivist theory. So it assumes that there's an underlying truth or an objective truth, if you like. So those are a simple way of describing the differences. So as I said, I'm going to throw you in the deep end with this example, with a very recent study to get you interested, because obviously we read about COVID every day in the news. And we read about vaccine hesitancy in the news every day. Why don't people want to accept a vaccine, or why don't they want to be vaccinated? Because on the face of it, you would think that everyone would want to be vaccinated. So I just found this article through putting this talk together, and it's based in Bradford, and it's based on a cohort study, a study that's been running for years in Bradford. So they've got a good connection with the community, and I'll come on to that in a minute. But it's about the people of Bradford and their views. Obviously, why is it important? Well, as I said, we can't work with people to encourage them to take up the vaccine if we don't understand their views, their positions, their concerns. So let's get into it then. What's the study design? So as you read the document, and I'm just thinking if anyone's got any questions. I can't see any questions that are coming up. So if anyone's got any technical questions, then please just shout out or message Alice, and Alice will be able to help you. So study design. So the authors state all these boxes I've copied from these PDFs that I've sent around. So the authors say this is a descriptive, inductive, qualitative study. It's completed as part of a larger mixed method longitudinal research study. So that's telling you a bit about how they collected data, how they ran this study. So it's descriptive. Qualitative, and that's the first thing that people might think about qualitative research. It's gathering a load of opinions. People might think of a similarity with TV, when on the news they interview people in the street. Well, that can be a way of gathering views, but it may also be a bit limited in that it's descriptive, and it may not get into an in-depth understanding or a deeper theory, and we'll come on to theory a bit later. So what methods did they use? They used in-depth interviews to explore citizens' health experiences and beliefs. So this is a bit of theory that they're touching on. What do we mean by health beliefs? And there's a whole kind of body of psychology that describes health beliefs. So again, just coming back to that sort of quantitative, qualitative comparison, beliefs aren't something that you can easily put numbers on. You can't easily measure them. So obviously we need to ask people about their beliefs. We can't do a lot else. So fair enough, we need to interview people to find out their views. So that's what they've done. So who do we interview? How do we decide who to interview? Well, again, this is in the methods in the next part of the paper, sampling and data collection. So another kind of strength of a qualitative study can be sampling diversity. And again, this is quite different from quantitative. So a quantitative method will obviously would generally try to come up with quite a homogeneous sample where everyone's quite similar. People are outside of that description are often excluded from the study. In contrast with qualitative, we're quite interested in those differences and diversities, and we may actually want to recruit a group of people who are quite different or diverse. So they talk about their sample being of diverse ethnicity and age, and a few more details there. With qualitative people, to interview people, first you've got to recruit them. You've got to get their interest in the topic. Again, these are people in the community, so it's it's not like recruiting from a clinic, for example. These people aren't patients, and it's quite important to build trust in the community so that people will be willing to talk to the interviewer and give up their time and also trust the interviewer to hold their information confidentially. So there's a bit in the text here about people being embedded in community settings, so developing that trusting relationship. And in the box down here we've got recruit through trusted contacts. Also, snowball sampling was used to build the sample. So the first people who were recruited were then asked if they knew of other people who might like to be recruited, and so you build a larger sample. I've just got to dodge what I've said in what I've covered in these blue boxes here. Just making the point that for qualitative research, sometimes the usual strategy in quantitative research doesn't always work. That the adverts and the posters up in the clinic trying to recruit people doesn't always work. So having trusted contacts is important again. So that's a bit about the sample. They did interviews, and this is what some of the people said in the interviews. So here I've got a bit of a quote of what some people said, one person said, and a bit of the interpretation by the authors here. So again, we're speeding through a qualitative study. So this person, for example, said it got a bit too much on the internet. So we're talking about vaccines and COVID vaccines and concerns about vaccines. It was just too much. Everywhere you look was just things going on. Some are true, some are not true. So it's the authors are highlighting this confusion that was out there, particularly on social media. And the authors comment on this, or as I say, interpret this in a qualitative sense. So they're talking about the interactions with the false news, and I've just highlighted these couple of points. They distance themselves, referring to them as something that they're dismayed or amused by, scrolled past or ignored. So they're talking about this sort of confusion and seeing these mixed messages from social media and elsewhere, and their participants are commenting how they responded. And the authors here claim that the narratives revealed much more complex responses. So I'm just highlighting this as a way that the authors have interpreted the interviews. That is, that they're not just straightforward accounts, and this is where the strength of qualitative research is it's not just recording and listing what everyone said, but it's interpreting, it's making sense and drawing additional meaning, maybe trying to find an underlying meaning. So the authors here are interpreting what's happened, and at the note I've made, identifying an underlying phenomenon. So although the participants are saying one thing, the authors are trying to understand what that might mean in more depth. So that they believe that the participants were actually saying something else, underlying this kind of confusion. And that is that although they're aware of this fake news or false news, the participants are making the point that they kind of scroll past, ignored, that they're capable of identifying true facts from all this false news. That's what I think the authors are interpreting here from the participants' quotes. Just got to move away from that quote here. Spoke of feeling confused after reading something online. So trying to tease apart the true facts about vaccination from the fake news. So here's another quote then. So this person said that there was a concern that they're just using people as guinea pigs who experienced discrimination for many years, and we've been focused for talking about the Roma community here. They're noting that this information is spreading about coronavirus, and that they're going to offer immunization because they're going to trial it out on us. So again, the authors interpret that there's a feeling of control by these participants by scientists, and this idea of guinea pigs as people who are almost disposable. That's the kind of impression that this participant is giving in this quote. So this is a really important perspective, really important view that this participant is giving. And it's not unreasonable, because we know that science isn't always ethical, and there have been mistakes and poor practice in the past. So it's a reasonable concern for people to have, that they are concerned that scientists may be experimenting or treating people like guinea pigs. So it's really important for this study to pick up and record these concerns that are voiced by participants, in order that those concerns can be addressed in public media, in order that medical people, that scientists can clearly communicate and can improve their communication to reassure people that they're not being experimented on. That yes, this is a new vaccination, but it's reliable and trustworthy. So this can all help people developing policy, people developing public messaging about how to communicate. And it might be that there are messages for this particular group, a particular ethnic group that this participant is a member of, or for more general communications with diverse ethnicities. So that these are important findings of the study, and moving swiftly onto the discussion of this study. The study aimed to explore health beliefs. So again, I'm just highlighting that little bit of theory. Whilst this study was mainly exploratory, descriptive, there's a bit of theory there that they're interpreting health beliefs from what these people have said in interviews. And the theme that I've mentioned, talking about confusion, distress, and mistrust of the messages about vaccinations. So that's quite a quick run through that article, and I'm just going to move on a bit to thinking about how your work, about your interests, and I'm going to move into the breakout room in a second, and just sort of raising that there's lots of different questions that we can ask in qualitative research, and might help to think of it in this way that I've sort of broken things down. So it might be about individuals or members of populations. These can be patients, or they can be members of the community. We might call them, we might identify a vulnerable group within the whole population. It might be about diverse experiences. A qualitative research project can also be about organizations. It can be about services, but these are quite different kind of research questions. So that's one point I want you to think about for your topic or for your interest. Is it really about the service and how, I guess a lot of you work in the health service or social care service. Is your interest about that service, or is it about a patient group or a population group? So that's the first two. Again, I have to move sideways here. So the bottom one I've got here is practitioners and professionals. Now, many of you are practitioners or members of a professional group. And I'm not a clinician, so I'm not a clinical profession. I'm a public health professional. But dynamics between professional groups are very interesting to me. So professionals relate to services, services relate to people, professionals relate to people as well. So there's interactions, but each of these are kind of at different levels, and that's quite important to think about when you're thinking about a qualitative research project. Are you really interested in the experience of the individual, patient, civilian? Are you interested in a service, how organizations work? Are you interested in how practitioners work? Maybe you want to get a group of professionals to work in a different way, but then you have to understand that profession and members of that profession. So as you saw from that first study, that was mainly about a population group in people of the city of Bradford and their view of public messages about vaccination. So that mainly fits in that top group there. Great. Okay, so hopefully the next one is breakout groups. So what I'm hoping to do is hopefully we'll be in the same groups, and what I'd like you to do is discuss in your groups your particular areas of interest, whether you've got a particular research topic to explore that you're interested in, are there a particular group of people who you think might be most informative to address your particular interest, as I said, members of the public, or there could be professionals, etc. What type of questions do you think might get to the heart of your particular interest? How might you phrase those questions to get to the real topic, or even the underlying issues that may not be obvious on the surface? So you may not have a clue about any of those questions, and you can just join in the discussion more generally. It doesn't matter either way, but hopefully between you within your groups you'll find some commonalities, some differences, and have a bit of discussion of different methods. So Alice, I hope you can do the breakout rooms again. I'm hoping we can have 15 minutes and then come back and continue the presentation. Thanks. And hopefully I'll now talk a bit about how we use theory in our interpretation. And I said as I was introducing that first example of a research study, that it was quite descriptive, but maybe not wasn't a lot of interpretation in there. And I think that the real strength of qualitative research is to bring in that interpretation. Basically, qualitative research is sociological research, social science type methods. And that involves social theory, sociological theories. And those are either grand theories like Marxism, or they're micro theories of how practice works, how practitioners work together. So there's a load of theory to choose from. There's no shortage of theories out there. And that first example that I went through, as I said, was quite descriptive, which is fine. But to really bring the strength of qualitative research, that sort of interpretation is really important, because then you're really saying something with the study that you're reporting. And that can say something much more powerfully. You know, sociological research can be a thing in itself, but we're often thinking of using these methods to bring about change, if you like, change in practice, change in policy. You know, where are our findings going to go? What are we trying to do with our findings? And that's coming back to that point that was made about positionality. In a way, what are our aims more generally as a healthcare worker, as a public health person? So it's really good to think about theory. Now, if I start to talk about theory, that would be several more hours. So there's obviously limited amount I can do today. So what I'm going to try and do is use two more examples of papers to bring in examples of where theories can be brought into into the study, and how they can add to the interpretation. So it's not just presenting what was said, but it's making meaning of what was said, and that's the real strength of qualitative research. So I'm going to share my screen again. And I don't know whether it was helpful to have me on it or not. I'll leave me off, I think, this time. So again, not again. This study was conducted by my colleagues, led by Justine Schneider, who's a professor in sociology and based at Institute of Mental Health in Nottingham. So I know the background of some of this work, and I know what's gone into it, if you like. So it was a study of home care workers, domiciliary workers, and again we see this in the news quite often, don't we? Of 15 minutes care visits. You know, how do people care? How do people receiving that care manage when they've got 15 minutes of a care worker visiting and then disappearing again? So this study was trying to explore what makes quality of care good, what makes home care good. And they use several different study methods, and I'm going to be talking about one in particular, which is participant observation. So that these two researchers, Samantha Wilkinson, Lucy Perry Young, became care workers for this study. So that they were both doing their PhD, I think, and they took on the role of a care worker, a healthcare assistant type level worker. So they became trained in the care work that was done by that organisation. They went out in visits, home visits, and became one of those researchers. And this is a an example of an ethnography method. So it's participant observation is the method. What they describe in the introduction to this study, if you read the paper, was this paradox of home care workers, where obviously in status and in amount paid, salary, these workers are get a fairly raw deal, but they also value their job. They value what they do, and they value their care role. So there's a bit of a paradox there, and the authors state in the abstract here of this approach that they've used to interpret these findings, their study. So that they've talked about different value systems, different values that we put on different work roles, if you like, and they've used this theory called orders of worth as a way of understanding their observations, as I say, participant observations. They also carried out interviews and collected diaries. So that's what I'm going to be talking about, is how these researchers collected data and then applied this theory to make more of it, to make it understandable, and also to condense what was hours and hours of observations, hours of interviews. How do you condense that and make something meaningful out of it? Oops. So again, there's a couple more quotes, excerpts from this paper, talking about the approach and the perspective. That's slightly different from methods. You might call it methodology. So that their focus was on the day-to-day practice of home carers, that they weren't so interested in the organisation or those other sort of structural questions, actually in the practice. And the design was ethnography, as I've mentioned. So the methods that they describe here: participant observation over 10 months. So these two researchers were home care workers for 10 months. So they were doing home visits over that period. So that gives them a huge amount of time to observe what care workers do, because they were actually being those care workers. They could observe it themselves. Secondly, they worked with a number of other home care workers, not researchers, and asked them to keep diaries of their practice. So they also had these research diaries, 11 other workers. So they've got a huge amount of data coming into the study. And here's the kind of the data that they collected. So they've got field notes and diaries, and one thing the point I'm making is that often people think of interviews as the key part of qualitative data, but observations are important as well. So you can see the amount of data that they've got to handle: 87,500 words. So huge amount of data to process, if you like. And just at the bottom here, I've given you a bit of a kind of schematic. So this is the data coming in interviews or in observation notes. What do we do with that? That goes into the computer. So this is called computer-aided qualitative analysis. And in this case, it's NVivo, which some of you may have heard of. That, just like quantitative analysis doesn't do it all for you and produce an answer. It's just a way of bringing the data together. So it doesn't do the work for you, unfortunately, or fortunately. So here are the research team on the right, and they're the people who are actually interpreting and analysing the data and making sense of the data from this computer database. And just at the bottom, I've shown a couple of arrows coming back, just to indicate that there's some iterative or going back to the data, possibly even going back to the notes or the recordings, possibly even doing more recordings or more observations if there's a particular question that's unresolved. So there's a potential for iterative progress within a qualitative study. It doesn't all have to be predefined, if you like. So here's some examples of the data that they collected that's in this paper that I've shared with you. So this is a quote of a work from the diary of one of the care workers expressing her grief that one of her clients has died, and reflecting on the care that she gave to this client, saying that she really did go the extra mile for this client, and this going the extra mile was picked up as a theme by the researchers, where they identified that was a characteristic of the work that was done, was going above and beyond, kind of thing. And this within this theory that I mentioned earlier, orders of worth, that they use this theme as a way of showing dedication, and that dedication is promoted or valued by the organization. So this is where this theory is coming in to help us understand the meaning of what's being said. Another coding, coding is how we understand the transcripts, the text. And another coding is between practical activities and social activities. So there might be personal care that's practical, but also the care workers are chatting to the clients, taking them out for a visit, so there's kind of two aspects. But this observation, and from another diary, I was talking about some frustration with that. This client actually just wants to be left alone. She doesn't want that social activity, and that the care worker describes this kind of frustration, and she actually just decided to get on with the housework, doing some vacuuming. And the sort of analysis of this is that the care worker understood this client in enough depth to know that it was best just to get on with it, with a task like that. And in fact, the client then started doing some dusting as well and watered the plants. Now, this is a kind of, could be seen as a kind of occupational activity for the client, instead of sitting watching TV or whatever she might have been doing. She joined in the activity. And there's also a kind of communication in working together on this task of housework. So again, the interpretation is that the practical task enabled, it was practical, but it enabled the client to be engaged in that, rather than just being alone, as she stated that she felt she wanted to be. So again, taking those quotes from this worker, and sort of interpreting a bit more about the meaning and a bit more interpretation there. We're not going to go through all this, obviously, but again, this is the table that shows how this interpretation, how this theoretical framework is applied to understand the data within this study. So as you see, the headings on the left, common principles, driving forces, who is esteemed at the bottom. These are the characteristics that come from the theory, and on the right are some examples from the findings from the data. So I've mentioned the ones in blue. I've just mentioned in the few quotes that I've shown. Affection and attachment are social driving forces. Housework is a practical driving force, and driving force means something within this theory. And again, at the bottom there, being dedicated, going the extra mile. This is what's held up and valued by the organisation. So that the researchers, the authors of this paper, have used this theory to make sense of, if you like, all this data that's coming in from these different methods of this study, and used it to make sense of, to interpret the findings, and put a bigger picture, if you like, put them into a bigger picture, so that they make sense, so that they can be used in future, and potentially organizations can look at these findings and consider how they then apply to their work. What are the driving forces of our organization? So, and then they can reflect on those theories as well as just the raw data, which might have been limited. So that this is a way of now, if any of you are sort of quantitative, you kind of think of generalizability. We don't really talk about that in qualitative work, but using these theories, we can then think how that data might apply to other aspects of work, other localities, other settings. We think of that more as translating those findings, or translating that interpretation to a different setting. So it's not generalizable, but it is useful, can be applied in other settings and to other populations even. So again, that's a difference between quantitative and qualitative. This was another article I'm not going to describe today, but from the same study where they describe the method of these diaries, and one member of the group here today asked about grounded theory, and and this article talks about constant comparison, which is the key interpretive theory within a link to grounded theory. So I'm not, you can look that up, but I'm not going to go into that too much more today. Grounded theory is a whole other lecture. So that paper was my way of giving an overview of ethnography of these observations, and understanding and interpreting, using theory to interpret. I'm now going to go on to give a final example of the papers that I've shared with you, and of course I've got to draw upon my own research at some point. Everyone does that, don't they? And to bring in another theoretical approach or perspective, which is realist evaluation. This has become very popular in healthcare research over the last 10 or 20 years. Coincidentally, if you're interested, we've got a group in Nottingham that supports researchers, a kind of peer support group to help people with realist methods. So if you're interested in that, then there's a link at the bottom of the presentation. Now, I kind of say that as a proviso, because this is quite a, it can kind of blow your mind in a way, the level of complexity. So we're certainly not going to be able to get into the depth of any of that. But again, I'm just giving you this as a kind of insight into another theoretical approach, just to give you some range of different approaches. So for this study, we're interested in an approach called comprehensive geriatric assessment, which is basically multidisciplinary care for older people. And we're particularly interested in the care home setting. And that's particularly interesting because you have GPs visiting the care home, but GPs don't work in the care home. You might have nurses in the care home, social workers, care assistants, all these different people with their own knowledge, their own training, and how do they come together to deliver, if you like, or to care for their residents in a person-centered way, and in a holistic way. So this study is a literature review, so it's quite different from the others. but this realist approach is another qualitative method, really. So realist evaluation tends to be about field work. Realist review is more about literature work. I've noted I've got 5 minutes left, so I'm going to speed through this one. Leave you all confused. So the idea behind realist work is that you come up with some ideas of theories that you think may be important, and you kind of take those theories to the work that you're looking at, in this case the literature, and you think about theory of action, theory of change, and you consider how that is represented in the literature in this case, and in particular try and identify what outcomes are described in the literature and how they relate to the contexts in which the work has been reported. And this refers to mechanisms which are in the real domain. Now, real as opposed to empirical. Everything that we see and everything that quantitative measures are all in the empirical world, if you like, measures of things or measures that can be recorded. Blood pressure, for example, is empirical. The real is this theoretical domain which has a kind of commonality, and it is kind of underlying. It's kind of invisible, but it helps us understand why things happen. It understand how causality of events. So we're trying to understand events by postulating that there's a context and a real mechanism which leads to an outcome. Again, just give you a kind of whistle-stop tour, really, and just to give you an idea that there's a substantial theory, and you've got to seriously get your head around all that theory. But then once you've done that, then in theory, you can make more powerful claims, and you can investigate in more depth. So the way I looked at this literature was that what was actually happening in this CGA multidisciplinary approach was that individuals have complex needs. People with frailty or dementia, for example, they have lots of different needs, and it's a bit like putting a jigsaw together. Now, some people are good at doing sky on the jigsaw. Some people like the detail. So that's, in a way, different professionals come at things from different angles. So that's what I kind of helped me to think about and make sense of this topic, really. Again, I'm not going to go into the detail of this, but this was a literature search with the academic databases that I've named at the top there. In the end, we only identified 21 articles that really helped us understand what was going on. And again, we used NVivo, as I mentioned, and we transferred those findings into Excel in order to be able to play more easily with different themes and different topics, different quotes. And we came up with with 3 of these context mechanism outcome configurations, and I'm just going to describe one here. So this is kind of the central one, which is about developing a care plan. So once we kind of know what an idea of the needs of the individual, we need to sort of put them together into this multidisciplinary plan. So the context that we identified from these research articles was the communication between the multidisciplinary team. The mechanisms, as I said, these are kind of real mechanisms, if you like, underlying mechanisms. So the discussion of the needs and goals to gain a shared understanding of the individual. So none of the research articles that were included actually stated that. Obviously, that's our interpretation of what all these articles were saying. So that's what I mean by real. It's our interpretation of the underlying causative, what caused a good outcome. So this led to a unified working between these different professionals, and the outcome was that team members feel that they've contributed to the comprehensive care plan, so that they're working together in a team despite having different perspectives. And the kind of empirical outcome, if you like, is that prescriptions were updated. So, maybe there was a medication review, or maybe there was a change in the needs of the individual. So the team came together and came to a shared understanding of what needed to change in the treatment plan. So, as I said, that was a bit of a whistle-stop tour, and it probably phased you a bit. And I'm just going to come back to you again now. In the breakouts, we sort of explored what your research ideas are, and now I'm thinking as you go back to your setting or your locality, what might you do next to consider your next steps? And sorry about that. And another way of thinking about all these different perspectives is this concept of quality of care. And I just highlight this again because effectiveness is in there. All the trials that we do are all about effectiveness. These other factors aren't easily addressed by trials. So things like safe run out of time on my voice. Safety, timeliness, efficiency and equity are amenable to qualitative studies, not so amenable to trials. For practitioners in the group who might not be actively doing research, how can you get involved? Well, you can find researchers who are working on your topic of interest. Talk to them about stakeholder engagement. How can you work with fellow clinicians or patient and public involvement? You can contribute to that. Sorry, I'm struggling now. But also, it's good to get it involved in research networks, and you can do this through Twitter and social media. I mentioned ARC and East Midlands Research into Aging Network, of which I'm coordinator, of course. So that's a few resources to maintain your interest and progress your ideas. Thanks very much for your interest. We're out of time, just overrunning. Sorry about that. I hope it's been interesting. Please get in touch with more questions, and hope to see you at the next seminar. So thanks very much.
Thank you.
Thank you, Neil.